every session in our series of free sessions preparing for one. Of course, we had 2 sessions before. The first one was an orientation about the exam, and the second one was about the modes of inheritance, which was illustrated by Dr. Zaid. And today, inshallah, is our third one. Of course, we will discuss today the interpretation of the arterial blood gases. Actually, this is one of the important topics, not only in the exam, of course, but in our clinical practice. And we can say that this is a mandatory question in part 1 exam. Of course, during the session, if you want to ask any question, you can ask me if anything is unclear. And of course, at the end of our session also, we will give a time to answer any question you have.
Okay.
So before we go through the steps to interpret the arterial blood gases, first we should have some information, a quick introduction about some basic concepts in what's called the acid-base balance. This is a very sophisticated topic. This is a very big topic, of course. We won't cover in a single session, but we will just cover or pass through the very basic and superficial concepts which will help us to understand this part and to answer these kind of questions. Actually, in general, for part 1, this is a general rule in this basic science. You have to be so basic. You won't go through much details in each subject. You have to go through the very basic and superficial things that will help you in your clinical practice. We are not having an exam in the physiology subject. We are having an exam in the obs and gynae specialty. So we just will take what will help us in our clinical practice. So this introduction will contain some very basic concepts regarding this acid-base balance. First, and of course, I know that most of us know these concepts, but just we are reminding ourselves by it, that the pH value of any fluid, especially, of course, what's more important for us in the blood, is a measurement of how much hydrogen ion concentration in this fluid, in this blood. And of course, the pH value has an equation which depends on the hydrogen concentration, but of course it's not mandatory to know this equation. It's a very sophisticated equation, and of course the lab devices now can give you the automatic pH value of this blood, so we don't have to know this equation, but just we have to know that the pH value is just a reflection of this hydrogen concentration in the blood. And when I have more hydrogen ions in the fluid or in the blood, that means that the blood becomes more acidic, and this will be reflected as a low pH value. Of course, we have a normal pH value for the blood, which is about 7.4, or strictly speaking, a range between 7.35 to 7.45. When the hydrogen ion concentration increases, this means that the blood is more acidic and that the pH is low. So we can say that the value of the pH goes in an opposite direction to the value of the hydrogen ion concentration, but at the end they give the same meaning. By another meaning, that the low pH value means a high hydrogen ion concentration, means acidity, and a low hydrogen ion concentration means the alkalinity of the blood means higher pH value. So when the pH value is less than 7.35, that means that the blood is acidic and I have much hydrogen ion concentration. When the pH is more than 7.45, that means that the blood is alkalotic and that I have less hydrogen ion concentration. So this is very basic knowledge about the pH value, and that's what is relevant for us to know that the pH is a reflection of the hydrogen concentration, and the normal value of the pH is 7.35 to 7.45. Below this range, that means that the blood is acidic. Above this range means that the blood is alkalotic. So this is our first concept, which is the pH value. So what makes this pH of the blood is in this normal range? What is responsible for regulation of this pH? How come this pH is maintained in this normal range 7.35 to 7.45? I can say simply that I have two parts, two arms or two components, whatever you like to name them. These two arms or these two compartments are the respiratory compartment and the metabolic compartment or the metabolic component. These two systems counteract with each other to maintain the pH of this blood in the normal range. So I have the respiratory system or the respiratory component and the metabolic component. Each one of them counteract the other to maintain the pH in the normal range. So what is the representative of the respiratory system or the respiratory component? It will be always the carbon dioxide, CO2. So the CO2 is the representative of this respiratory component, while the representative of the metabolic system or the metabolic component will be the bicarbonate. So CO2, bicarbonate are going face to face to regulate the pH of our blood. But let's know something, that the CO2 is favoring in the direction of the acidity by another means, that as we have increase in the CO2, this will take the blood in the direction of the acidity. And of course, we are going to know why in a while. And at the same time, also the bicarb favors the direction of the alkalinity, or want to take the blood in the direction of the alkalosis. So CO2 increase leads to acidosis, while bicarb increase leads to alkalosis. But of course, when both are in the normal range, the pH will be, of course, in the normal range. So speaking about the respiratory component, we have CO2, which is the representative of this system. When it increases, the acidity of the blood increases. Why? This is because we have an enzyme called the carbonic anhydrase enzyme. This enzyme will convert the CO2, as shown in this equation, into what's called the carbonic acid, the H2CO3. And this acid actually is a weak acid, and it will turn rapidly into hydrogen ions and bicarb. So as long as I have more CO2, this will lead to more free hydrogen ions in the solution, and this will lead to acidity. So that's why when CO2 increases, it leads to the acidity of the blood. But by speaking about bicarb, which is an alkaline component, it will lead to alkalosis of the blood when it increases. And when we speak about the bicarb, we have to Remind the kidneys, regarding this point, have a very important role in maintaining the acid-base balance. Why? Because the kidneys have the ability to reabsorb the bicarbonate or excrete bicarbonate in the urine. The same also for the hydrogen ions. So when I have any increase in the acidity of the blood, so simply the kidney will try to reabsorb more bicarb and generate more bicarbonate to try to neutralize this acidity. And the opposite, of course, when alkalosis occurs, the kidney will try to excrete to get rid of more bicarbonate to neutralize this alkalosis. So the kidneys, or we can say the metabolic system represented by the bicarbonate, also have the second major role in regulating the pH. So we can say that I have a counteraction between the CO2 and the bicarb to maintain the pH of our blood. The CO2 favors acidity while bicarbonate favors alkalinity. As we also talk about the bicarb, we have another definition. We have another concept that's very important to know. Another concept which also reflects the amount of the bicarbonate in our blood, which is called the base excess and the base deficit. What is the base excess or the base deficit? It's simply the quantity of the base or the bicarbonate which is above or below the normal range I have in our body. We have in our body, which is normally from 22 to 28 milliequivalent per liters or 22 to 26 regarding or according to other references. So when I have an excess bicarbonate more than this normal range, this is called base excess. When I have bicarbonate level much below than this normal range, this is what's called the base deficit, or by another meaning, a negative base excess. So when I'm talking about the base excess or the base deficit, it's like an indirect presentation of the bicarb level in the body. So I can say that I can talk directly about the bicarb level, or I can talk by another way, which is the base excess or the base deficit. And normally the base excess or the base deficit range, that is normal range, from -2 to +2 milliequivalent per liter. So I can have -2 below this range or +2 more than this range. This is normal. But less than -2 or more than +2, this is called metabolic, base excess or base deficit. And as I am talking about the bicarb, which is the representative of this metabolic system, so any increase in the bicarb level or a positive base excess will lead to or can represent metabolic alkalosis, because of course when the bicarb increase, the alkalinity increase. And of course when the bicarb is low or below the normal range, or when I have a negative base excess or base deficit, this indicates metabolic acidosis. So again, this base excess or base deficit is another way to represent the level of bicarb in our body, and normally the base excess or the base deficit is from -2 to +2. And of course, when we go to the steps of interpretation of the ABG, you will know how the level of the base excess or the base deficit will confirm my diagnosis when I interpret an ABG. I hope it's clear up till now.
Yes.
Okay. So I have terms: acidemia, acidosis, alkalemia, and alkalosis, like I was talking. Actually, this is can give us some confusion in our practice, but let's clear that these terms, acidemia, acidosis, alkalemia, and alkalosis, can be used interchangeably. But actually, strictly speaking, The term acidemia, or any word containing this part emia, is talking about something in the blood. So acidemia means the blood is more acidic, while acidosis means the underlying process which leads to this acidemia. By another meaning, ketoacidosis, lactic acidosis, these are the underlying processes which can lead to acidemia. And the same can be taken for alkalemia and alkalosis. So alkalemia or acidemia means what's happening in the blood. The acidosis and alkalosis means the underlying processes, the etiology of these disturbances in the pH. But in our clinical practice, we can use these terms interchangeably. When I say acidemia or acidosis means that the blood is acidic. This is, of course, in our clinical practice, and this is normal. Okay? So also we have another concept. We have to know this concept, and very superficially also, what's called the buffer system. The buffer system is the neutralizing system. This is the system which try to neutralize, try to minimize any change in the pH, try to keep the pH in the normal range. It's actually consists of a weak acid, like we have mentioned, the carbonic acid, for example, with its conjugate base. This conjugate base is what remains when the hydrogen has left the acid molecule. To be more clear in this part, like here, we have a weak acid, which is the carbonic acid, and we have this conjugate base, which is the bicarbonate. This bicarbonate is formed when a hydrogen ion leaves this acid molecule. So this is what's called the buffer, and that's why the bicarbonate acts as a very important buffer system in our blood, because the bicarb involves this balance between the CO2, between the carbonic acid, and between the bicarb itself. So this is why the bicarb is a buffer system, because when there is much hydrogen ion in the blood, the bicarb will bind to this hydrogen ion to form carbonic acid, which will be transformed into water and CO2, and then the CO2 it will be excreted from our body, and the opposite, if there is marked CO2, it will be dissolved into carbonic acid, which will be then dissolved into hydrogen ion and bicarb. So this is a two-way relationship like this, and that's why the bicarb is mandatory in buffering or neutralizing or maintaining our pH in the normal range. Also, from the very important buffer system in our body, the hemoglobin. Why? Because when we look at the chemical structure of the hemoglobin, we will notice that the hemoglobin has two groups in its chemical structure. Of course, details are not required, but just to know that we have two groups, the carboxyl group and the amino group. As we can see here, this hydrogen ion in the carboxyl group can leave this carboxyl group and go to the amino group to form NH3. So if the solution become more basic, more alkalotic, and I need some hydrogen ion to increase the acidity of the blood again, so this carboxyl group will leave this hydrogen ion to the solution, and if the solution is become more basic and I want to get rid of some hydrogen ions, this group will take this hydrogen ion to form NH3. So simply speaking, we can say that this group is a factory of hydrogen ions. So the fluid or the blood becomes more basic. It will release this hydrogen ion in the blood to become little acidic again, or to maintain the acidity. And when there is extra hydrogen ion in the blood, we can consider that this group is the like the way to get rid of these hydrogen ions, and this group, amino group, will take up any or pick up any extra hydrogen ion to form NH3 when the solution becomes more acidic. So this is how hemoglobin acts as a buffer system also in our blood. Now let's talk about what's happening in pregnancy, and this is of course what is very important to us to deal with pregnancy. In general, pregnancy is associated with a slight respiratory alkalosis. Why? When I'm talking about respiratory alkalosis, means that I have something in the respiration or the respiratory system that leads to increase in alkalinity of this blood. We said, what is the representative of the respiratory system? It's the CO2. And what is the action of CO2? Usually the action of the CO2 that it wants to take the blood in the direction of the acidity. But when I'm talking about respiratory alkalosis, that I'm getting rid of carbon dioxide. And that's what happened in the pregnancy. Because in the pregnancy, there is what's called increase in the minute ventilation. The minute ventilation is calculated by multiplying the what's called the tidal volume by the respiratory rate. The tidal volume, which is the normal amount of air which goes in and out during the normal quiet respiration. When I multiply it by the respiratory rate, which gives me the minute ventilation, and actually in pregnancy, the respiratory rate usually is the same. It's not changing, but the tidal volume is increased in pregnancy. That's why totally the minute ventilation increased, and this will this happen in pregnancy. Why? Because in pregnancy, due to an increase somehow in the basal metabolic rate, I want more oxygen and I want to get rid of the extra carbon dioxide formed during the increased basal metabolic rate. So I have to get rid of this carbon dioxide by increasing the minute ventilation. This is what's happening in pregnancy. So in pregnancy, there is an increase in the minute ventilation to compensate for the increased demands for O2 and the increase in the CO2 production. So the body tries to get rid of this extra carbon dioxide by increasing this minute ventilation. Also, the progesterone, which of course increases during pregnancy, will stimulate the central respiratory system or the respiratory center to make a further increase in this minute ventilation. So I can say that in pregnancy, the net effect or the net result is a slight increase in the partial pressure of the oxygen and slight decrease in the partial pressure of the carbon dioxide. So the net result in pregnancy due to the increase in this minute ventilation is that I have low pressure of carbon dioxide and increase the partial pressure of the oxygen. And actually this is very important because I need a diffusion gradient for the carbon dioxide to be passing through the placenta. I know that the fetus wants to get rid of the CO2 in its blood. So I must have a pressure gradient between the fetal circulation and the maternal circulation. In the fetus, the partial pressure of the CO2 is higher than the mother, so it can pass from the fetal circulation to the maternal circulation to be excreted. So this slight respiratory alkalosis is important to maintain this diffusion gradient for the CO2 to pass through the placenta from the fetal to the maternal circulation. And we have mentioned in the start of our session that the respiratory and the metabolic system are usually going face to face. They counteract each other to maintain the pH. So I know that the bicarbonate, which is an alkaline component, Here, it will try to compensate for this respiratory alkalosis by decreasing in its level. So the metabolic system will decrease the bicarb level in a trial to reduce this change in the pH value. But still, the net result is slight respiratory alkalosis, a degree of respiratory alkalosis which we cannot consider it's pathological. It's physiological and it has no medical considerations or medical consequences on the mother. So I have in pregnancy slight decrease in the partial pressure of the carbon dioxide due to increase in the ventilation, and I have a compensatory fall in the bicarb level to neutralize or try to reduce this change in the pH value. Is everything clear up to now?
Yes.
Yes, great. So the most important thing, or why I'm talking about this respiratory alkalosis, the thing is that during labor, this is what matters in this situation. During labor, and because of the maternal effort during labor, we have what's called the maternal hyperventilation. There is an increase in the ventilation due to increase in the respiratory rate and the effort which is done by the mother. This maternal hyperventilation will lead to excretion or getting rid of more carbon dioxide. So the respiratory alkalosis will be more extreme. And because of the relatively short time scale during labor, the compensation by the renal mechanism does not occur, and so the consequences of alkalosis are more marked. Here at this level, especially during labor, the respiratory alkalosis become more apparent, more extreme, and here, because of the short time, the renal system cannot compensate for this increase in the degree of respiratory alkalosis. Does it matter for the mother? Actually, this is not of great concern to the mother herself, but maybe this is of some concern to the baby. Why? Because the alkalosis, or when there is some sort of respiratory alkalosis, this will lead to somehow increase in the affinity of the maternal hemoglobin to oxygen. When there is a kind of respiratory alkalosis, when I have less CO2 in the blood, here the hemoglobin will bind more tightly to the oxygen, and so the oxygen delivery to the fetus will be lower than usual. So when the CO2 is less in the blood and hemoglobin binds more tightly to oxygen, this will lead to less delivery of oxygen through the umbilical vein to the fetus, and this leads to some sort of metabolic acidosis in the fetus due to, of course, when there is less oxygen in the field or in the blood or in the body, the cells of the body will go in another direction called the anaerobic metabolism. Of course, this is explained in details in biochemistry. And of course, the net result of the anaerobic metabolism is development of lactic acid and lactic acidosis. So I can say that there is some sort of less oxygen delivery to the fetus in labor due to the extreme, if there is extreme hyperventilation or extreme maternal effort in labor. And of course, if there is others, or there are other problems to the fetus, and there is other like compromise to the fetus, this can have a detrimental effect on this fetus. So I have to be careful during labor that the mother don't go through a case or a state of hyperventilation or extreme hyperventilation, and because this respiratory alkalosis can have a detrimental effect on the fetus. Not only this, but also when we mentioned that the hemoglobin, when there is a decrease in the CO2, it will bind tightly to O2. The reverse will happen in the fetus. Now the fetus has some sort of deoxygenated blood because the level of oxygen coming from the mother to him or to the fetus is low. So now the hemoglobin of the fetus, when there is low oxygen, will bind more to CO2. So now CO2 also will accumulate in the fetus. This will lead to another form of acidosis in the fetus, which is respiratory acidosis. So extreme maternal hyperventilation will lead to two consequences in the fetus, both metabolic and respiratory acidosis. Metabolic acidosis due to the anaerobic metabolism and the buildup of lactic acid, and respiratory acidosis due to accumulation of CO2. So during labor, we have to be very careful that there is to avoid a state of maternal hyperventilation, especially if we have an already compromised fetus by like when we have a fetus known that it's IUGR or growth restricted, or when I know that there is some sort of placental insufficiency and I know from the antenatal care that there is a deficient blood supply to this fetus. So again, simply speaking, alkalosis, which happen in the pregnancy, is physiological respiratory alkalosis due to increase in the minute ventilation, but it can be more extreme if the mother has an hyperventilation during labor, and the alkalosis will lead to binding of the maternal hemoglobin tightly to the oxygen. This will lead to less delivery of the oxygen to the fetus and can lead to either respiratory or metabolic acidosis, or both, of course. So this is what's happening during pregnancy. So the final thing to know before we go to the steps of interpretation of the ABG, that we have 4 clinical scenarios now. We have 4 clinical scenarios which must be interpreted very carefully. The first one is I have acidemia, which arises from respiratory acidosis. This is caused by underventilation and accumulation or build-up of carbon dioxide. So when carbon dioxide is high, this is respiratory acidosis. And we have alkalemia arising from respiratory alkalosis. This is the opposite. When CO2 decreases due to some sort of hyperventilation or overventilation, either this overventilation
बाहर से चल ले ये एकदम क्यों कॉल कर रही है
Please turn off your mics, please.
मैं नहीं सुन रही उसकी बात
Hello.
हेलो जी
Kindly turn off your mic if you have surrounding noise. Okay. So when I have decrease in the CO2 level, I have what's called respiratory alkalosis. How to decrease the CO2 level? By overventilation or hyperventilation. This can be done during vigorous artificial ventilation during anesthesia, or even voluntary. If you do some sort of voluntary hyperventilation, this will lead to fall in the CO2 level and respiratory alkalosis. So anything related to the CO2 is called respiratory. Acidosis means increase in the CO2. Alkalosis means decrease in the CO2. On the opposite side, we have the acidemia resulting from metabolic acidosis, and this may be either due to a metabolic problem like lactic acidosis, diabetic ketoacidosis, which lead to production of more acid in the body, or due to ingestion of acid from outside, like when there is salicylate overdose, or by another meaning, we can also say toxicity of salicylate, or the third mechanism is failure to excrete the acid in cases of renal failure. So in metabolic acidosis, I have one of 3 options. The first one is a metabolic process which lead to building up of the acid, or failure to excrete this acid in renal failure, or to ingest acid from outside, like in cases of salicylate overdose or salicylate toxicity. So these three mechanisms can lead to metabolic acidosis. And the fourth clinical scenario is alkalemia resulting from metabolic alkalosis. But let's notice something, that metabolic alkalosis is a term, like we can say, need to be revised, because I don't have any metabolic process in the body which can lead to build up or accumulate an alkali in our body. But usually the metabolic alkalosis result from either two options: loss of acid in cases of severe vomiting, if there is a case of severe vomiting and there is loss of the acid from the HCl, of course, of the stomach, or intake of alkali in cases of overdose and symptomatic management of peptic ulcer, or overdose of intravenous bicarb in the management of metabolic acidosis. But I don't have a metabolic process in the body which will lead to buildup of bicarbonate. So metabolic alkalosis can be or can occur by either overdose of bicarb in management of metabolic acidosis, or due to loss of much acid from the body, like in cases of severe vomiting. So these are the main four clinical scenarios, two of them related to the respiratory system or the respiratory component, and two of them related to the other system, which is the metabolic or the metabolic component. So these are the four clinical scenarios I have to put in my mind during interpretation of arterial blood gases. So now, this is the important part now, how to interpret or how to read the ABG, or how to answer this question in the exam. Interpretation of the ABG, like I was saying, that is a mandatory question. You can face one or two questions in the exam, and of course in your clinical practice. So to look at our mind, we have 6 steps for the ABG analysis. We will take the titles and we are going to explain each title separately. The first one, I'm going to note down the pH and check either it's acidotic or alkalotic. Then I'm going to check the two arms responsible for the regulation of the pH, the CO2 and the bicarb. I'm going to check the CO2 level. I'm going to check the bicarb level and to see which one of them is abnormal. And then I'm going to match this CO2 or the bicarb with the pH level. And of course, when I know who is the criminal, who is the responsible for this change in the pH, I'm going to check the other system and see if it goes in the opposite direction or not, if it's trying to compensate for this abnormality or not. And the last step is to check the O2 partial pressure and saturation, to check if there's some sort of hypoxia or hypoxemia or not. These are the 6 steps to analyze the ABG. Now let's illustrate them in details. First, I'm going to check the pH, and of course I know that the normal range is from 7.35 to 7.45. It's if below 7.35, like we mentioned in the start of our lecture, it will be acidotic. If it increases above the level of 7.45, it is alkalotic. And I'm going to note down either there is acidosis or alkalosis. This is my first step. Then the second one, I want to analyze the carbon dioxide. The normal partial pressure of carbon dioxide is from 35 to 45 millimeter mercury, and below 35, of course, when CO2 decreases, we know it will lead to alkalosis, and when it's more than 45, it leads to acidosis. So I'm going to check the CO2 level and note down if it is abnormal or normal, and if it's abnormal, here it's acidotic. And of course, the same I'm going to do for the other arm, the bicarb. I'm going to check the level of bicarb. I know that the normal level of the bicarb is from 22 to 26 or 28 according to reference in the exam. And if it's below 22, then the patient is acidotic. And if the bicarb is high, above the level or above the normal level, the patient is alkalotic. So I have now pH level, I have CO2, I have bicarb. Now I'm going to match between the pH and both CO2 or the bicarb. By another meaning, if I have acidotic pH and I saw that the carbon dioxide is increased, and I know in my mind that the carbon dioxide usually favors the route of acidity, then the acid-base disturbance is being caused by the respiratory system, and we have to say it's a respiratory acidosis. This is an example. Another example is that if the pH is an alkalotic pH, and when I check the CO2, I found that it's normal, but when I check the bicarb, I found that it's high. And I know in my mind that the bicarb level, when it increases, it lead to alkalosis. So here, the incriminated or the, can I say, the responsible arm is the metabolic arm, and I can say that there is some sort of metabolic alkalosis. This is how to match the pH by the result of the CO2 or the bicarb. And then, after I know who is responsible for this, either the CO2 or the bicarb, I'm going to check the opposite system, if there is some sort of compensation or not. Because when there is some sort of, for example, respiratory acidosis, the bicarb level will try to increase to neutralize this acidity. So, if I have a pH which is acidotic, increased CO2, and the bicarb is increased, so I can say that the CO2 matches the pH. The CO2 is high and it's acidotic, and the pH is also acidotic, and so they match each other, and the condition is respiratory acidosis. And here the bicarb in the opposite hand is trying to increase to maintain this pH or to try to compensate for this respiratory acidosis. So I can say that the bicarb here is trying to compensate, or there is some sort of compensation from the metabolic system. Of course, this will be more clear when I solve with you some examples. And at the end, I have to check the normal, the level of the partial pressure of the oxygen and the oxygen saturation to know if there is some sort of hypoxemia or not. So these are the normal values. And in general, I usually recommend you to memorize these normal values. These are the normal values, or I can say these are the only normal values for part 1 MRCG I recommend you to memorize together with the semen analysis result. Otherwise, other references will be given to you in the exam. Even the APG references will be given for you in the exam. But for being in the safe side, we have to memorize the normal levels here because they are simple and of course they are not difficult to be memorized. So to confirm what I was saying, that the pH is normally from 7.35 to 7.45. If it's decreased, means acidosis. If it increased, it means alkalosis. The same for the partial pressure of the carbon dioxide, the normal level of from 35 to 45 millimeter mercury. If it decreases, it leads to alkalosis. If it increases, it leads to acidosis. The bicarb 22 to 26. If it decreases, it leads to acidosis. If it increases, leads to alkalosis. The partial pressure of the O2, when it decreases, of course, lead to hypoxemia. The same for the saturation of the oxygen. You can depend on either of these two parameters. You can use the partial pressure of the oxygen or the saturation. By the way, the definition of the partial pressure of the oxygen means how much oxygen is dissolved in the blood. But the saturation means how much oxygen is bound to hemoglobin. So this is the difference between the partial pressure and the saturation. The partial pressure means how much O2 is dissolved in the blood, and on the other hand, the saturation means how much oxygen is bound to hemoglobin. Also, another important parameter to look for is the base excess or the base deficit, which also will help me to confirm my diagnosis, like we are going to see in our examples now. So, to apply for these steps, this is an example. Here I have pH of 7.35 27. I have carbon dioxide of 53. I have partial pressure of 50. I have O2 saturation of 79. I have bicarb level of 24. So this is the first step. pH here is less than 7.35. So this is my first note. I'm going to note down that pH is acidotic. Okay? This is my first step. Does anyone have any question?
No.
Okay. So here is my first step. I'm going to mention the pH, which is 7.27, much less than 7.35. Therefore, my first note will be I have an acidotic pH. Okay? So I'm going to go for this step. Here, I will check the first arm, which is the CO2. Here, the CO2 is 53. So I know that CO2 is from 35 to 45 and 53 is much high. So the CO2 usually favors the acidity. So I'm going to check or note down that the CO2 is also acidotic and go for the third step. Bicarb level. Now I will check the bicarb level, and here the 24. The normal level is from 22 to 26 or 28. So bicarb is normal. So bicarb is not incriminated in this problem at all. It has no role in this problem. So this will take me to the fourth step, which is matching the pH with either of these two arms. Here I can say that the CO2 change matches the pH change. So the condition is respiratory acidosis. So when I see that the CO2 is acidic and the pH in general is acidic, so the CO2 is the responsible one for this abnormality. So I can say that the CO2, which is the representative of the respiratory system, and I can say that this is a kind of respiratory acidosis. Now we will check the other arm again. We have mentioned that bicarb is normal, so there is no kind of compensation here. The bicarb level is normal, and the body doesn't or didn't start to compensate for this respiratory acidosis, as the bicarb is still in the normal range. And at the last step, I'm going to check the partial pressure of the oxygen and the O2 saturation, which are low, both are low. This means that there is some sort of hypoxemia, and here I can reach my final diagnosis, which is uncompensated respiratory acidosis with hypoxemia. Of course, this indicates that the patient has an acute respiratory disorder. Respiratory disorder which leads to underventilation and accumulation of the CO2, and in the same time it's acute because the body mechanisms of compensation still didn't work and the bicarb is still normal. So this patient has an acute respiratory disorder, or I can say it has an acute respiratory failure. So this is an example of how to interpret our APG. Now we have 4 questions. I'm going to present them. You are going to think and to tell me the answer. You can, of course, open your mics and discuss with me. This is our question. These are the parameters given to you. These are the reference range and these are the values, and these are the options given. How to interpret this arterial blood gas. And we are going to follow our steps in a systematic way.
Metabolic acidosis, acute with hypoxemia.
Again, can you raise your voice, please? I didn't hear your answer.
A. Metabolic acidosis, acute with hypoxemia.
Metabolic acidosis, acute with hypoxemia. Okay, this is your answer. Okay, and another answer also. Yes, A. Okay, let's interpret before we show the answer. pH, yes, it's acidotic. So my first note will be acidotic pH. It's 7.24. Then I will check the first arm, which is the carbon dioxide. Here it's 44. It's nearly normal. So of course, surely it's not responsible for any abnormality because it's normal or within the normal range. So I'm going to note down that it's normal. Then I'm going to look for the bicarb level. Yes, here the bicarb is low, 18, and this means that the bicarb, when it decreases, it leads to acidosis. So of course, bicarb here is acidotic. Okay, then I'm going to match the pH with CO2 and bicarb. CO2 is normal, bicarb is acidotic. Of course, this is a kind of metabolic acidosis. And check the oxygen level. First, of course, I'm going to check the CO2 level to see if there's kind of compensation. Of course, we have mentioned it's normal, so there's no compensation. So this is kind of acute disorder. And the PO2 level, of course, is low, and there's some sort of hypoxemia. And also, as I have mentioned, that the basic excess also can confirm even my answer that I already have a negative base excess here or base deficit. And of course, negative base excess or base deficit means that there is some sort or indicates metabolic acidosis. So my answer, of course, is metabolic acidosis acute with hypoxemia. So my answer is A, metabolic acidosis acute with hypoxemia. So we follow these steps systematically. This will be very easy and we won't lose any mark in this part. Another example.
E.
A. Oh, sorry. A.
Oxygenation.
Please raise your voice. I can't hear you. Your voice.
E. Metabolic acidosis with acute normal oxygenation.
Metabolic alkalosis, acute normal oxygenation. So you mean
B.
that?
The answer is B.
B? Okay. Okay. Let's interpret before showing the answer. Okay, the pH is, yes, 7.52. It's alkalotic, yes, right. Check the carbon dioxide. Here the level of carbon dioxide is, it's 348. I know that carbon dioxide is, when it increases, lead to acidosis, but the pH is alkalosis. So note this and note this, okay? Now let's look for the bicarb. Bicarb here is increased, and increased bicarb leading to alkalosis. So when I match the pH with both arms, pH is matched with the bicarb. So it's a metabolic disorder. This also will be confirmed by the base excess. I have an extra base excess. Okay, of course, not in every example will give you the base excess or base deficit. Some examples can be given, others are not. But here I have a base excess of positive 14. So this confirms that it's some sort of metabolic alkalosis. And When I look for the carbon dioxide, it goes in the opposite direction. So this is a kind of trial for compensation now. The body starts to compensate by under-ventilation or building up of carbon dioxide to neutralize this alkalinity. And when I look for the partial pressure of oxygen, it's normal. So I don't have any kind of hypoxemia here. So the net result or the result is metabolic alkalosis acute with normal oxygenation. Of course, I can say that there is some sort of compensation here, but still I have to stick to the options given because this kind of question is said to be the single best answer. So of course, from this answer, this is the single best one. Yes, I know that the body start to form some sort of compensation, but do you have any choice here say that there is some sort of metabolic alkalosis with compensation? Of course, if in the options there is one option say that there is metabolic alkalosis with compensation or compensated, I will say yes, you are right. But also I want to add something. When the condition is compensated, you will not see the pH in this way. If it's compensated, you will find that the pH is turning to normal again. That's why I can say that it's still acute. Still the compensatory mechanisms didn't work up till now. So 7.52 is a high pH. If it's compensated, I can see that the pH is starting to be 7.46, 7.47 like this. This I can see now the compensatory mechanism is working. But still up till now the pH is so high. So I can say it's still somehow acute condition. Okay? So here the best answer or the right answer here is B. Metabolic alkalosis acute with normal oxygenation. Third one.
D. Respiratory failure acute.
Yes, your answer is D. Respiratory failure acute. Okay. Does any other
C.
one has any other choices or any other opinion? All of you agree with the answer D? Okay. So yes, let's check or interpret again. 26 is the pH, so it's acid. When I look for the carbon dioxide, yes, the carbon dioxide also is high. So carbon dioxide, when it increases, lead to acidosis. So acidosis here and acidosis here. Bicarb is normal level. So of course, no rule in this disorder, and this is a kind of respiratory acidosis with still normal oxygenation and no compensation. So this is a case of acute respiratory disorder, acute respiratory failure, like we have answered in our first example. So the right answer, of course, is D, respiratory failure or acute respiratory failure. This is excellent. Okay, the last example today.
Respiratory acidosis with metabolic compensation. C.
So you go for respiratory acidosis with compensation. Okay. Any other opinions?
C.
Okay. Any other? Okay, so all of you agree with the C answer? The range of CO2 is from 5.4 lakhs to 1 or 6.2 kPa or kilopascal. So, of course, he will give you the normal reference in the exam, don't worry, but this is, of course, high CO2. Like here, look at here, 7.5 is very high. The normal is 4.4, 5 to 6 or 6.1. So here, this is a high CO2. So you all agree with the answer C. Okay, let's interpret. We have pH of 7.25, so it's acidotic. And I have high CO2. Of course, when CO2 increases, it leads to acidosis. So I have here acidotic. But let's look at the bicarb. What is the level of bicarb here? Is it low or high?
Low.
Yes, when bicarb is low, what is the net result?
It's E.
Yes. When bicarb is low, it also leads to acidosis. So this is not a compensation. This is a kind of mixed disorder. Yes. I have here respiratory acidosis. I have here metabolic acidosis. Okay. So I have mixed metabolic and respiratory acidosis. There's some sort of incidental happened between, okay, like renal failure is also respiratory disorder, something like this. So I have mixed metabolic respiratory acidosis. And of course, most of you answered it wrong because you didn't read the choices. Actually, you have to read the choices, because if you read the choices, of course, this will, take your attention. What is mixed metabolic respiratory acidosis? So please, in the exam, this is a very important general in the exam. The exam is not just a question. The exam is a question and options. This may help you to remember the answer or the right answer, okay? Or maybe a source of confusion. So these options must be read very carefully before even thinking about read the choices. Okay, so in this condition, I have mixed metabolic acidosis and respiratory acidosis. And this is our last example for today. Before I start the questions, I have to, for the answer here is E. I want to remind you that we still have another fourth question, which will be held on Friday, March 15, 4 p.m. Greenwich time, GMT. This will be held, this is upon statistics and how to interpret a forest plot chart or forest plot graph. And this is very important also in the exam for part 1 and even for part 2. And this will be held, inshallah, by Dr. Desiree. And of course, she is one of the best teachers of statistics. And also, we remind you of a course which will be held on the start of April. This is our regular 3-month course. And if you want to know more information about this course, please send an email to info@medexamexpert.com or send us a message on our Facebook group, MedExamExpert. Of course, this course will be, inshallah, held on the start of April and will be instructed by Dr. and me, inshallah, Dr. Muhammad Helmi. So we will be there for 3 months from the April to the exam to guide you, inshallah. So thank you so much for your careful listening. If you have any question, please do. Not only for the session, if you have any general question, you can ask me I'll be pleased to answer you, inshallah.
I missed previous 2 lecture. How can I get this lecture now?
We have a YouTube channel. You can just send a message to our Facebook page. They will send you the link of this channel. All our free sessions are recorded there. You can listen to them, okay?
Okay.
Any question about this session or any other? Dr. Sajida, yes, of course, you can send a message to Dr. Hassan Haider or the page MedExam Expert, or an email to info@medexamexpert.com as shown here in this slide. It's of course easier to send a message to our Facebook group. They will guide you. Please, I couldn't understand the relation between acid base and pregnancy. Okay, I have mentioned that in pregnancy, this is a physiological change in the pregnancy. The tidal volume, which is the normal, when you do a normal respiration, which is formed of inspiration and expiration, there is a certain amount of air which enters your lung and exhaled again. This is called the tidal volume. In pregnancy, this tidal volume increase. So the net result is an increase in the minute ventilation. The ventilation which is the multiplication of the respiratory rate by the tidal volume. It's called the minute ventilation increase. This leads to more excretion of carbon dioxide. So the carbon dioxide level in pregnancy is somehow slightly decreased than in the normal individual. So when the carbon dioxide decreases, of course, we know that this carbon dioxide is acidotic. So when it decreases, it leads to alkalosis. And so I have some sort of respiratory alkalosis. And it's a physiological change. It's not some pathological change, okay? But this respiratory alkalosis can be more extreme during labor, because there is some sort of maternal hyperventilation. You know, when you saw a woman having labor, you see that she's exerting an effort and doing hyperventilation. She's breathing so quickly, so she's getting rid of more carbon dioxide, so the alkalosis will be more extreme. As I have mentioned, that this may be not of great concern to the mother herself, but may be of great concern to the fetus, because when there is low carbon dioxide in the body, the hemoglobin will bind to oxygen. You can say that the hemoglobin in the body wants to bind to anything, either oxygen or carbon dioxide. So when I have low carbon dioxide, the hemoglobin will bind tightly to carbon dioxide. When I have low carbon dioxide, the hemoglobin will bind tightly to oxygen. This is a two-way theory, like what's called the Poor and Haldane effect. Of course, this is some details in the physiology. I don't want to confuse you right now, but in general, when there is low carbon dioxide in the mother's blood, the hemoglobin will bind tightly to the oxygen. So the oxygen in the maternal blood will not be delivered so easily to the fetus. This will lead to some sort of anaerobic or hypooxygenation in the fetus. So if the fetus is already compromised by anything like vascular insufficiency or placental insufficiency, or the fetus is already affected, this may be of great concern to the fetus. So I have to be careful, and that's why we monitor the fetus during the labor, because this acidosis which can happen to the fetus can lead to fetal compromise. So this is what I wanted to know, or what I want you to know from this, or why I have to be serious upon the maternal hyperventilation or the alkalosis, which can be extreme during labor. But in general, the most important thing to know is that the pregnancy is a kind of some sort of respiratory alkalosis due to increase in the minute ventilation. I hope it's clear now.
Yes.
Any other questions? You are welcome.